Welcome to the deep dive. If you really want to get what moves the needle in healthcare today, what drives the money, the policies, the big research breakthroughs, well, you've got to look beyond just that single patient chart. So today, we're diving deep into this huge world of secondary data sources. Might sound dry, but it's fascinating stuff. Our goal, to give you the inside track on how healthcare information works. We'll follow the data trail from like one doctor's note all the way up to these giant national databases. We'll figure out who's using it, why, and yeah, touch on the big security headaches too.
Okay, so first things first, we need to nail down the basics. Primary versus secondary data. It's fundamental. Think of primary data like the original source code. It's the actual documentation the doctor or nurse creates during a patient visit. And importantly, it's usually got the patient's name right on it, patient identifiable.
Gotcha. So the actual medical chart, the notes from surgery, the prescription list, that's all primary. The stuff that says Jane Doe, born January 1st.
Exactly. Secondary data, then, is everything derived from that primary stuff. It gets organized, compiled, put into indexes, databases. You get the picture. Now, the secondary data can sometimes still identify a patient. Maybe you need it for follow-up calls or specific research where you have to link back. So you might have a name or a medical record number attached.
But the really powerful stuff, the data that shapes policy and big decisions, that's usually the aggregated data, right?
Absolutely. Aggregate data is key. That's where we basically strip out the individual names and look at groups. A classic example, calculating the average length of stay of the ALS for everyone who had a certain procedure, grouped by their diagnosis-related group, or DRG. That number tells a hospital a lot about efficiency, but nothing about, John Smith specifically.
Okay, that makes the distinction pretty clear. So why bother? I mean, it sounds like a massive effort to collect, code, and crunch all this information into secondary forms. What's the payoff? Our sources point to four main reasons. Maybe start with improving care, quality performance, and patient safety.
Right, this is huge. It's how the system checks itself. This data is used to evaluate care quality, think of measuring infection rates after surgery or readmission rates for heart failure. That info gets shared, often mandated, with agencies like CMS, the Centers for Medicare and Medicaid Services. It keeps hospitals accountable and, ideally, pushes them to get better.
Okay, so quality checks current performance.
Yeah.
Then the next big use seems to be about shaping future care, research.
Correct. Research relies heavily on this. How else do you figure out if a new drug actually works better than the old one for thousands of people? Groups like PCORI, that's the Patient-Centered Outcomes Research Institute, they use this kind of derived data to compare treatments and help doctors and patients make, well, smarter choices based on evidence.
Then we zoom out beyond the hospital walls to the whole community. That's population health, right? Sounds like tracking diseases and making wider policy.
Precisely. It's very interdisciplinary. Think about tracking flu outbreaks or something more serious. States have to report certain infectious diseases to the CDC. That whole information flow from the patient's chart, pulled out, anonymized usually, sent to the state, then up to the CDC. That's all secondary data in action. It's how we track epidemics.
And the fourth one, maybe less flashy, but essential, administrative uses, kind of the nuts and bolts.
Exactly. It's the behind-the-scenes stuff that makes the system run.
Yeah.
Budgeting, seeing patient trends over years for planning, even credentialing doctors, making sure they're qualified. These are the internal users, the hospital managers, the medical staff leaders. They need this data for benchmarking, planning new services, figuring out staffing, all that operational stuff.
Right, so internal users run the place. But then you have the external users, the ones using the data for broader goals. Researchers, government agencies.
Yeah, state health departments demanding reports on certain diseases, federal agencies like the CDC or HRQ analyzing national trends, researchers looking for patterns. It's a whole ecosystem outside the facility itself.
Okay, we know the why. Let's get into the how. How do you take all those individual patient records and make them, useful and searchable? You mentioned indexes and registries being the workhorses.
That's a good way to put it. They're the first level of organization. Let's start with the basic facility-specific indexes. Think back before computers dominated everything, though it's all digital now. If a hospital wanted to find every patient treated for pneumonia last year, they couldn't manually search thousands of charts. Indexes solve that.
So the disease index is basically a list sorted by diagnosis codes using ICD-10-CM, I assume.
Exactly. You look up the code for pneumonia and bam, you get a list of all the medical record numbers associated with it. And you've got the same idea for the operation index, but it's sorted by procedure codes, CPT or ICD-1010-PCS. Find everyone who had a knee replacement, for instance. And the physician index lists patients by their attending physician. crucial for things like quality reviews or tracking a specific doctor's outcomes.
Okay, so indexes let you find groups quickly by diagnosis, procedure, or doctor. But registries sound like they go deeper, tracking specific conditions over time.
Much deeper. That's where the real long-term insights come from. Registries are dedicated collections of secondary data about a specific disease like cancer or a procedure like organ transplants or a condition like trauma. They're absolutely vital for tracking patient follow-up for years, figuring out survival rates, looking at quality of life after treatment, that kind of longitudinal view.
Well, let's use the cancer registry as an example. That sounds like one of the most established ones. It's more than just a list, isn't it?
Oh, absolutely. The National Cancer Registrars Association, NCRA, helped pioneer this. The data is incredibly detailed. You get demographics, sure, but also occupational history. Was the person exposed to asbestos at work? Administrative info like insurance? And critically detailed pathological data, the exact type of tumor, the stage at diagnosis.
And you mentioned a unique identifier, the accession number, being key for tracking people over time. Why is that specific number so important?
All right, the accession number. It's not just the patient's regular medical record number. It's unique to that patient for that cancer diagnosis at that specific hospital in the year they were entered into the registry. This is critical because cancer follow-up can take decades. You need to track people down years later for survival stats. Without that stable, unique accession number linking everything together, that long-term follow-up just wouldn't be feasible.
Wow, yeah, that really highlights how crucial accurate data entry is from the start. Okay, moving on. Another critical area, trauma registries.
Trauma registries focus on injuries, usually severe ones from external causes, car crashes, falls, violence. They track how many injuries happen, how they're treated, and what the outcomes are, including deaths. This data helps trauma centers plan resources, understand injury patterns in their community, and improve care protocols.
And measuring trauma severity must be complex. You can't just write badly injured.
No, you need standardized scales. They use the Abbreviated Injury Scale, or AIS, to rate the severity of injury to each specific body part or system. Then, for patients with multiple injuries, which is common in trauma, they calculate an injury severity score, the ISS. It gives a single number reflecting the overall severity. This allows for fair comparisons, comparing outcomes for patients with similar overall injury levels, even across different hospitals.
And trauma registrars need specific training and certification too, right? The CSTR.
That's correct. Certified Specialists in Trauma Registry. It reflects the complexity of the data they handle.
And then there are other specialized ones like birth defects registries, tracking issues in newborns, or immunization registries, which are really important for public health, making sure kids get their shots on time.
Exactly. Birth defects registries help identify trends or potential environmental links. Immunization registries are often population-based, providing a central record to avoid duplicate shots and send out reminders. They're crucial public health tools.
Okay, this is where it gets really, really big picture. We've gone from indexes inside one hospital to these detailed registries. But how does this data connect nationally? How does it influence policy and, importantly, money?
Right. Let's talk about the massive national databases. Payment is often the driver. Take the MedPeer File Medicare Provider Analysis and Review. This database pulls together claims data from acute care hospitals and skilled nursing facilities, but only for Medicare patients. It gives a good snapshot of demographics, charges, diagnoses, ICD codes, and DRGs for that population.
Okay, so useful, but like you said, the big limitation is it's only Medicare. Misses everyone else, kids, younger adults, privately insured folks.
Precisely. It's a piece of the puzzle, not the whole picture. Now, for safety and oversight, there's a really important one. The National Practitioner Data Bank, the NPDB. This wasn't optional. Congress mandated it.
Ah, the NPDB. That's the one hospitals have to check when hiring doctors, right? The credentialing backstop.
Exactly. It tracks things like medical malpractice payments made on behalf of a practitioner or actions taken against a doctor's license or clinical privileges. Any hospital, clinic, or health plan must query the NPDB before credentialing a provider. It's a direct link between secondary data and patient safety policy.
So MediPAR for Medicare Payment Insights, NPDB for provider safety checks. What about getting that comprehensive view across all payers? You mentioned HCUP earlier.
Yes, HCUP, the Healthcare Costs and Utilization Project. This is a game changer run by AHRQ, the Agency for Healthcare Research and Quality. HCUP's genius is that it gathers state-level data encompassing all payers, Medicare, Medicaid, private insurance, even the uninsured. It provides databases like the Nationwide Inpatient Sample, NIS, and the state inpatient databases. SID.
So that's how researchers or state officials can see the full picture. Like, how many uninsured people were admitted for asthma last year across the whole state?
Exactly. HCUP enables those kinds of analyses that you just can't do with Medicare-only data. It looks at costs, usage patterns, outcomes across the entire healthcare spectrum. Huge for research and policy.
And we shouldn't forget the real basics, the vital statistics. Births, deaths. Seems simple, but foundational.
Absolutely foundational. Collected by the National Center for Health Statistics,
Yeah.
NCHS, within the CDC. Data on births, deaths, fetal deaths, marriages, divorces. This is bedrock epidemiology. And there are smart links built in. For instance, birth certificate data is linked to the infant death data set. This allows public health folks to analyze risk factors for infant mortality in incredible detail.
And making sense of all this, especially connecting different data sets, requires some serious organizing principles. That's where the National Library of Medicine comes in.
Yes, the National Library of Medicine, NLM, plays a crucial, if sometimes unseen, role. They develop bibliographic databases like Medline, which indexes medical literature. But critically, they also build vocabulary systems.
Like the Unified Medical Language System, UMLS. Why do we need that? Don't standard codes like ICD cover it?
Not entirely. Different systems, different researchers, different clinical notes might use slightly different terms for the same concept. A billing system might use one code, a research database a different term, a doctor's note yet another phrase. UMLS acts like a massive translation dictionary. It links all these different terms and codes together, ensuring that when different databases try to talk to each other, they actually understand each other. It's essential for interoperability and making secondary data truly usable across systems.
Okay, let's ground this with a real-world example. We've mapped the data pipeline. How does this actually play out in, say, a major public health campaign?
Well, a great example is the National Youth Tobacco Survey. That survey relies on collecting secondary data information about tobacco use, attitudes, demographics, all aggregated up. And analyzing that data over time allowed public health officials to spot the alarming rise in e-cigarette use, vaping, especially among middle schoolers. That wasn't just anecdotal. The data showed a clear, sharp trend.
So data collected perhaps initially in doctors' offices or schools gets compiled, analyzed nationally, and suddenly you see this vaping explosion. And that data directly fuels policy changes, flavor bans, public health warnings, school programs.
Exactly. It shows the power loop. Data collection informs understanding. Understanding drives policy and intervention. It demonstrates the incredible value of this whole secondary data infrastructure.
Yeah, there's always a but, isn't there? With all this valuable data floating around, the security risks must be immense.
Immense is the right word. We absolutely have to talk about the security imperative. This huge repository of secondary data, even when aggregated or de-identified to some extent, is a massive target.
And we're not just talking about someone losing a spreadsheet. This is organized crime, sophisticated attacks.
That's right. You have hackers constantly trying to get in, often using phishing emails or other social engineering tactics to steal credentials and access databases with personal information. And then there's the really nasty stuff like ransomware, where cyber criminals encrypt a hospital's entire IT system, including patient records and secondary databases, and demand huge payments to unlock it. Healthcare is a prime target because downtime can literally risk lives, pressuring them to pay.
So for any organization building or using these indexes, registries, databases, security can't be an afterthought. It needs strong technical defenses, constant monitoring, and really robust employee training on how to spot threats.
It has to be part of the core infrastructure. The data is just too sensitive, too valuable, both for good and, unfortunately, for criminals.
So we've covered a lot of ground today. We went from the initial doctor's note, that primary data, saw how it gets organized into indexes within a hospital, then built into these incredibly detailed long-term registries like for cancer and trauma, and finally, how it all feeds into these giant national databases, MedPAR, NPDB, HCUP, vital statistics that shape policy, research, and how care is delivered and paid for. These systems are really the hidden engine driving public health knowledge.
They truly are. But as we've seen, this deep dive highlights a fundamental tension. There's this undeniable, powerful need to share data, aggregate it, analyze it, learn from it, to improve population health, make research breakthroughs, and ensure quality care. Yet at the same time, there's this absolute responsibility to protect that data fiercely against increasingly sophisticated cyber threats to safeguard individual patient privacy.
It's a real balancing act.
It is. And that leaves us with a critical question, really, for you to think about. As we move forward, how do we strike that balance? How can policymakers, healthcare organizations, and technologists practically reconcile the push for more open, transparent health data with the very real and growing danger of cyber attacks? Where does that line get drawn in the future?